hypotension, addiction, impaired memory, increased risk of falling. Not to be used more than 3 days. Now coming to a specific drug combination, Sinarizine and dimenhydrinate, there are certain recommendations, traffic highway recommendation, which says that they diminish cognitive and psychomotor performance. They do not recommend driving after having this drug. Simple calculation, simple mathematical problem solving abilities are decreased. Now, Sinarizine dimenhydrinate anti-pyramidal side effects are, in a study conducted retrospectively with 15-year data, 172 cases of drug-induced Parkinson, 74 were Sinarizine induced. Now we coming to the next bigger class, the stimulant class, that is beta-histine. It is the only non-sedating anti-vertigo drug. The mechanism is increases circulation to the inner ear and increase vestibular function through activity on H3 receptors. A dose of 48 to 72 mg provides reasonable symptomatic relief in subacute cases of vertigo and shown to facilitate vestibular compensation. The doses are usually tailor-made, but AIL recommends 48 to 72 mg per day as a reasonable dose to treat subacute vertigo. Beta-histine 48 mg daily for 3 to 6 months is an effective and safe treatment for Meniere's disease and different types of peripheral vertigo. Use of higher dose 48 mg TID proven to be more effective in reducing vertigo attack. It is new information which has come in certain German studies. Now again, the commonly used medication all together put in a table. These are antihistamines. Sedation X EPS are the common side effects. Histamine analog like beta-histine can cause gastric upset, and also in case of asthma you have to be a little cautious. Benzodiazepines you can give, but obviously you all know that it causes sedation and addiction. Antiemetics, obviously if you have vomiting as a vegetative symptom, you have to give antiemetics. These being fluoroperazine, metoclopramide, dimenhydrinate, etc. Calcium agonists is a major group, Sinarizine, but they cause as a side effect sedation and EPS on prolonged use. Anticholinergic not very much used in vogue. Others, nootropics, pyracetam, and antioxidants like ginkgo biloba, but mechanism is not very clear. Surgery, not a routine procedure, considered in specific cases like unilateral Meniere's not responding to conventional medical treatment, refractory Meniere's disease, acoustic neuroma where the tumor needs to be removed, purulent labyrinthitis from chronic suppurative otitis media, and surgical correction of superior semicircular chiral dehiscence, perineal fistula, and recurrent BPP that is not responding to the liberatory megagas. And with that, I come to the end of this and thanks to Abor for helping me to prepare this.
Thank you, Dr. Dhar, for your excellent delivery on an exhaustive topic. Now we are privileged to have Professor S.P. Shah with us. You know him, he is a renowned neurologist, and I request sir to give some notes on vertigo so that we, the clinician and all other persons, are becoming benefited with his speech. Sir, please.
No, he has covered almost every part of vertigo. There is nothing left for me. Just I make one information. In children, the migraine patient, childhood migraine, they present as benign childhood vertigo. If a child comes with vertigo, we first think of whether it is a variant of migraine. That is one. And another commonly used test, probably has knows it but has not mentioned, that is brainstem auditory evoked response, BAER. In vertigo, whenever a patient comes with vertigo, I personally routinely advise BAER test, brainstem auditory evoked response. What we do, we stimulate the ear with a ringing sound, And the pathway for this vestibular nerve, it is first in the auditory vestibular, first in the auditory nerve, then auditory nucleus,
CP angle tumors.
auditory nucleus, then it is in the inferior olive, then superior something, forgot the term, superior longitudinal, and ultimately medial lemniscus, then in the auditory cortex. So if we take 5 waves, if the involvement is the peripheral part, say suppose auditory nerve up to the auditory nucleus, then we call it peripheral vertigo. If it is in the central part, that is from auditory nucleus up to the medial longitudinal inferior lemniscus, and inferior lemniscus, we call it central vertigo. So by BAER study, we can differentiate whether it is a peripheral vertigo or it is a central vertigo. That is by investigation. And the rest, but he has covered.
So then we should advise BR to everybody with patient coming.
Yes, if the patient, if clinically you think it is, if you are confirmed that it is either peripheral vertigo or it is central vertigo, then you need not do it. But if you are confused whether it is a central vertigo or a peripheral vertigo, then you can advise BAER, by which you can differentiate. And BAER also helps whether the patient is malingering. Malingering, patient is saying that he is not hearing anything. In that case, by doing the BAER, if you get the wave, you know the patient is malingering. Again, in children who cannot express very early, say about 6 months to 1 year age, you don't know whether the baby is hearing, neonate is hearing or not. In that case, if you go for BAER, if the wave comes, then you can at least say that his hearing system is okay, because the baby can't say I am hearing or not. That also helps.
Thank you, sir. Now the session is open for question and answer. I think everybody is not having vertigo, so you are just requested to give your questions so that Dr. Dhar will be very much pleased to answer and clarify if you have any doubt on the issue.
Just one clarification. We ENT surgeons usually use BAER for if we are suspecting CP angle tumor as a cause of vertigo. Your point is well taken, sir.
Many indications.
So is there any questions?